Hi everyone. Yeah, so I'm Lucy. I'm from the Allergy team in Bristol, and so we are the service that sort of provides tertiary allergy care for young people in the Bristol area, but also the surrounding areas. And actually, we're part of a greater network now in the southwest with Peninsula in the south of Wales. So it's quite an exciting field that's really coming into its own. It's kind of quite new, but something that I think a lot of you in primary care will see a lot of as well. So quite helpful to know sometimes what you can do, but also when might be a good time to refer people in to us. So there's quite a lot to cover. So I'm going to go quite quickly, but if you do have questions, just feel free to ask, or there should hopefully be some time at the end. And I've also tried to make it a little bit interactive because I think sometimes these Zoom sessions can be a bit overwhelming if you're not joining in. So please put your answers in comments or feel free to shout out. So allergic disease covers quite a lot of things. It affects people very differently at different times of their life. There's something called the atopic march, which you may not have heard of, but how atopic disease and an atopic tendency in someone that's over the lifetime. And so what you see in terms of features in atopy really changes. And actually the most important years are those sort of first 25 years in terms of developing these sort of diseases, and they're quite often worse in those teenagers and then actually tend to ebb off a little bit. It's really prevalent, so about 3 to 6 people 6% of people in high-income countries are affected by atopic diseases, and that's most prevalent in high-income countries and slightly less so in lower and middle-income countries, probably because of the predominance of parasitic disease in those places. And so you, I think, had some teaching from a colleague of mine, Rob, a few months ago, which was predominantly about food. Just for those that weren't there, but also as a kind of recap and revision, because it's something that you'll see a lot of. Thought we'd just very quickly go over food allergy, which is what you're going to be worried about, those babies that come in with lots of eczema, who maybe are really colicky, really grumpy, that you're seeing a lot of in the first 6 months of life, and then moving on into the sort of first 5 years where you're worried about food allergy. And really there are 2 different types. So you have non-IgE mediated and IgE mediated. IgE mediated are the ones that everybody really worries about. These are the things that parents will be really panicky about. They'll be thinking about adrenaline auto injectors, all the horrible stories that you see in the newspapers about children dying because they've had a sesame seed roll somewhere where they thought there wasn't sesame seed, or the child who had a milk coffee at Costa recently. And actually that's a kind of smaller subsect, and really they fall mostly, obviously there's always going to be those who fall slightly out of the traditional definition, but there are a couple of quite simple rules about IgE mediated allergy, those ones that you need to worry about that might go on to have anaphylaxis, and those ones who need testing. And those are that if they have symptoms to a food, it's going to be really quite soon. So 95%, 99% of children with an IgE mediated allergy, one that's dangerous, that might go on to develop into anaphylaxis, they're going to have symptoms actually often within the first 15 minutes, but always within the first hour, and at a push 2 hours. They're having symptoms for days. If it's not yesterday, that definitely wouldn't be the food. If it's tomorrow and that they're getting a rash, it's not an IgE mediated allergy. Doesn't mean that they don't have an intolerance. It doesn't mean that there's not something else going on. It doesn't mean that their concerns aren't legitimate, but it's not something that you need to worry about. It's going to turn into anaphylaxis. And the other thing that's a really important consideration is that it needs to be every exposure. Sometimes they have a bit of peanut butter and it's fine, and sometimes they have it and they get a rash. They don't have an IgE mediated food allergy. All of these food allergies, these IgE mediated ones, are based on primary sensitization, and the idea is that if you've got eczema as a baby, that's a real risk factor for developing that. And there are 8 big food types that kind of the most common, and that's things like milk, egg, nuts, well, peanuts, tree nuts, fish, shellfish, etc. And you can get sort of more niche ones, but on the whole, those tend to be the ones that we mostly see. And then you've got your whole other group of non-IgE mediated ones, and especially in sort of the first year of life, this is mostly going to be about cow milk protein allergy. And sometimes these can be really difficult to manage. We certainly see a lot of them in general pediatrics, in A&E, because these children could be really miserable. But the way really to define whether it is or isn't is all about whether it's every time, whether these are immediate symptoms, or whether this is something that's kind of more long-standing. And something that's really important is that a lot of women take milk and cheese and dairy out of their diets. And what you really need, it should make a big difference. If they've taken it out and their baby's still quite cranky, and they've put it back in and it's still, their baby's still quite cranky, it's not the dairy that's the problem, it's something else, and you need to do a bit more thinking and a bit more digging. And especially if people are taking, breastfeeding mothers are taking lots of dairy out of their diet, then you need to think about supplements. So whether they're on calcium, vitamin D and iodine, because it's a really important food group that they end up missing. And sometimes they're doing it because they want the best for their baby and they're willing to try anything because this baby cries all the time. But actually it's a really big thing to take out of your diet, especially if you're breastfeeding. The other thing to think about in food allergy is eczema control. All of these things are related, and having good eczema control is the most important thing to prevent food allergy, especially again in the first 6 months of life. You want your babies to be very greasy. And then sort of two kind of important learning points I think that we sometimes see, and that we would really appreciate as the allergy team, because we sometimes see this being done, and actually it's not very helpful, and sometimes it can actually be harmful. And that the first is to not do screening tests. So there is a place for screening tests in terms of allergens and food allergy, but really that's in quite complex non-IgE mediated food allergies where you've got a complex patient with lots of different things going on, and that sort of screening tests should be done within a tertiary service. If you so skin prick testing and specific IgE is all something that we do in allergy clinic, and on the whole we'd mostly prefer, I think, to do it in a tertiary service rather than for it to be done, because there's lots of issues with those tests and interpreting them. They're not very specific, they're not very sensitive, and there's a lot of nuance and niche within them. But if you are going to do a specific IgE test for a particular food, it needs to be something that you're quite confident this child has an allergy to, and not just a blanket screen, because it comes up with all sorts of problems. And part of that reason is because actually what we now know is these two studies that I've got on this slide, the LEAP study and the EAT study, and these are kind of really important randomized control trials that have been done in the last 10 years. And what they've shown is that what we used to do 20 years ago, where we told everyone to avoid everything, not eat nuts when you're breastfeeding, not eat nuts when you're pregnant, actually that was completely the wrong advice, and it makes you more likely to develop food allergy. What we need to do is get people to be having foods as early as possible into their diet really regularly, so at least twice a week. And those children who are really at risk of food allergy, we're actually now advising them to start weaning at 4 months to try and prevent the development of primary food allergy. And that's for those IgE mediated ones. So if you are seeing children, you need to, if there's one nut, if it's a walnut that they're allergic, seem to have allergic symptoms to, then absolutely they should be avoiding that, and they should be avoiding pecan as well because they're related. But they shouldn't be avoiding all nuts, because actually what you're risking is in that year that it might take for them to end up in our tertiary service, they've then avoided all nuts the whole time, and they've gone on to develop further allergies when originally it was just this one nut. And what we need to do is try and limit as much as possible the risk of developing an intolerance and being sensitized in the wrong way. So it's really important that they're only avoiding foods that they know that they're having reactions to, and everything else they're having a nice varied diet. So that's a really quick whistle tour of sort of food allergies before we move on to urticaria and rhinitis, which are the sort of focus of the session. Does anybody want to ask any questions? Okay, we'll move on for the sake of time.
Lucy, sorry, it was just more of a practical thing. I wonder if you move your microphone a bit closer to your face, because at times it's just a little bit difficult to hear what you're saying. It might work, it might not. Just might make it a bit clearer.
Is it this one?
I may have made it worse, sorry.
Wait, maybe I can hold them up here.
But that's okay. Yeah, that's good.
A little bit better. Sorry, it's a little bit windy here in Kew Gardens. So if anyone can shout out or put in the chat, does anybody remember what the eater's history is? So this is your sort of allergy focused history. It's used for food allergy, but you can actually use it for all sorts of things. Anyone got any ideas what any of it stands for? Sorry, I can't see the chat, so if someone could read it out, that'd be really helpful.
So Ruth said exposure. Did you hear that? Oh, exposure and timing.
A little bit.
Yeah, could you hear that?
Yeah, absolutely.
Exposure, timing.
Yeah, any others? So exposure, absolutely. So you're thinking children are exposed to different allergies or how adults are. You're also thinking about what the allergens are, what specific things is it that they might be allergic to, and are they sort of your typical, so the big 8 that I was talking about, or your sort of tree pollens, or is it something a bit weird that you might need to think about a little bit more? Timing, so that's about this differentiation between IgE and non-IgE. Is it something that's happening within the first 2 hours, or is it more delayed, and is it lasting for a long time, or is it that sort of typical IgE picture where it comes on quickly but it also fades off quickly within a few hours? The environment's really important, and that's when you're thinking about how much control is there over those allergens and exposure. Is it something at home or in nursery where actually those tend to be allergen-free spaces, or are we talking about teenagers who've been handed something by a mate of theirs that they didn't really look at? Reproducibility, as we talked about, it needs to happen every time. If it's and it needs to be that again, and those are the sort of patients that are quite good to refer to us. Symptoms, are they the typical IgE symptoms or the non-IgE? And then also, not in the eater's history, but another really important thing to think about is family history. And that's not, does mom have a food allergy? It's about inheriting this tendency. So it's all about whether they're atopic or not. So are there other atopic diseases within that immediate family? So then if we go on to talk about urticaria. So urticaria is an atopic rash, essentially. It's histamine, it's IgE mediated. It's all part of that same Th2 type 2 allergic immune system response. There's a 2 to 3% lifetime prevalence, so it's actually really quite common, and it's especially common in childhood. It can last for quite a long time. Even a sort of acute, immediate urticaria could be anything up to 6 weeks, and you're only really starting to think about whether this is something chronic after 6 weeks. Sometimes there can be triggers, but they don't have to be foods. And if it's always a food, then you're again going back to thinking about food allergy. But actually, the most common things that cause urticaria in childhood are that it is either viral, so viral illnesses are the most common trigger. And then the second most common is that it's just idiopathic. It's just their skin, they're just having this histamine release, and it's got nothing to do with anything that they've eaten or anything that they've particularly been exposed to. Urticaria can be associated with angioedema, so that's the sort of lip swelling and eye swelling. That can sometimes be quite scary. I think it's what parents and young people tend to associate with. But it's all part of the skin and mucosal system, and lip swelling and eye swelling itself, so angioedema, it's not actually related. It's not the same thing as having laryngeal swelling in anaphylaxis. It doesn't progress. You can have lip swelling isolated with urticaria. If you're not having other symptoms, you don't need to worry about anaphylaxis and sort of adrenaline and things like that. You can also have eczema that urticates, which can be quite confusing, and it can sometimes be a bit difficult to pull out. And those are, again, quite good people to refer into the allergy service. But eczema, because it is an atopic disease, because it's full of those immune cells that have a tendency to release histamine, it's more common almost in eczema skin to get bits of urticaria. And again, that doesn't mean that they're having food allergy. It's just part of the eczema process. Typically urticaria, so even chronic spontaneous urticaria, which is what we were talking about, that thing that lasts for longer than 6 weeks, actually on the whole it still tends to burn itself out. Sometimes that can take months, sometimes it can take years. Tends to come on in the sort of early school, early childhood, but you can get it into the teenage years. But it does tend to wear itself out and burn itself out, that process, by the end of your adolescence. One of the most challenging things about urticaria is, and these sort of allergic histamine type rashes, is actually identifying them. And it's something that no one is very good at. So pediatricians as well, like no one is that good at identifying urticaria. And it's quite difficult to describe as well. I think the nettle sting, the hive is quite a good description, but you need a parent to have been stung by a nettle or to have seen that to really understand. So I thought we would have a quick look at some pictures and we can decide what we think these children have. So this is a 9-month-old. She gets this rash, which is very much around her mouth and up into her cheek. It happens after she eats. And she doesn't get any of the symptoms. So she doesn't get angioedema, she doesn't get wheeze, she's not floppy. She just gets this quite angry looking rash around her mouth. What do people think this is? Any guesses?
So Ruth said local irritation, Lucy.
Yeah, exactly. So it's contact dermatitis. So it is local irritation. It's really common in babies, toddlers, anyone who smushes food around their face while they're eating. If we were all smushing tomatoes and things like that around our face, then we'd all have this sort of rash as well, realistically. There are some particular foods that release histamine, so things like aubergine, but also very acidic foods like tomatoes, raspberries, berries, they're all more likely to cause this sort of rash. And so sometimes you can have a family who come in and say, well, they get this rash and it only happens with tomato sauce, and it's only ever bought tomato sauce. It's not the tomato sauce that we make at home. And actually that's not because they're allergic to something that's just in shop bought tomato sauce. It's because of this histamine acidic E number type thing. Okay, so this is obviously not a 15-year-old, but if we pretend that this is a 15-year-old, she's got these bright red cheeks, almost a little bit on her chin. If you ignore that and just go for these bright red cheeks, it sort of happens mostly when she's at school, actually. It doesn't really happen at home. It's not really related to any foods. It's not sort of around eating or anything like that, but she does get, it really comes on. It can sometimes last for a while. She finds it really distressing. And she says sometimes the rash itself feels really hot. Any guesses? Anyone want to take a punt? There are no wrong answers. This is somewhat, we had a case that this is one of the first people I saw in allergy clinic that was referred. Okay, so this is flushing. So this is just an adrenergic response. If you've got quite an anxious teenager, someone putting on their body, it's going to be more likely anyway. It can be triggered by embarrassment or feelings of anxiety, and it's not allergic. But if it's coming all the time, you can imagine that someone might feel like it is, especially if they feel that their heart's racing when it's happening, or if they find that they're getting breathing difficulties, that this might be confused. The other thing is just to think about if it's just on one side, and this is more likely to happen post-surgery or in like very young babies who are getting lots of flushing but just on one side, then you need to think about the facial nerve, because you can get syndrome where you get lots of salivation and flushing just on the one side, and actually that's to do with facial nerve damage. And it's probably one of the only ENT referrals you'll ever do that they're quite excited about. Okay, so this one, if you can see, there are just some little wheals around here, just on the elbow. There are a few, they're in little patches, they're quite pink. This is a 10-year-old. She gets these lesions when she eats hazelnut, she thinks. They seem to come on and then they last for a few days. And sometimes actually they can leave a bit of a bruise behind when they fade as well. Anybody know what these are? Any guesses? No wrong answers. Okay, just for time, because we've got a lot to get through, I'm going to move on. So this is vasculitis. So this is vasculitis. The clue here is that it lasts for a long time, but also that it leaves a bruise. So things that leave a bruise that look like urticaria. So this does look like urticaria. It's got that wheal. It's got a kind of pink outside. It's got a white center. It can even sometimes have that white raised center as well. So really, it can be itchy as well. Sometimes it's tender. If it's tender, it's not urticaria. You need to think about vasculitis. And if it leaves a bruise, you need to think about vasculitis as well. And these children need an urgent referral to dermatology, because if they are having this vasculitic rash, it needs a skin biopsy, but also there needs to be some more digging. What else is going on that might have a vasculitic component? Are their kidneys okay, etc., etc. And this was another child, and she did come in as a query hazelnut allergy. And actually, when you sort of really dug down into it, she sometimes ate Nutella and sometimes that was fine. So it wasn't a hazelnut allergy. Okay, so this one, any guesses? They're not the best pictures, I'm afraid. All the pictures are from DermNet.
Looks like eczema to me.
Yeah, perfect. So it is eczema. And you can see sometimes it can have this sort of ashy, dry component. Sometimes it can be quite irritated and quite red. You're going to get different distributions in younger children than you do in older children, where they sort of then go on to have the more classic flexor type pattern of distribution. And really the reason to include this slide particularly is just to flag that we as a profession in this country aren't very good at identifying rashes in children with darker skin tones. And it's really something to think about, because they can all look quite different. Urticaria can be much more subtle. Eczema can sometimes be discoloring rather than red. It can look more pale. And there are some really excellent resources that I can signpost to people to sort of recap and revise that sort of thing, because it tends to mean that these children get referred quite late to the right services if they need them. And then this one. Any ideas? Okay, I'm going to whiz through because I realised we only got 5 minutes left. So this is urticaria. And you can see, you can't see the sort of pink and white centres, but what you can see is that raised, almost edematous looking skin rash. This one. Sorry, I can see that someone's posting, but I can't actually see what the message is. I'm going to assume you've got it right, and this is also urticaria. So again, this is just one wheal, and again, you're not really getting that colour so much because it's much darker skin tone. Sometimes you can just get one wheal, it's still urticaria. And then this one. So this again is urticaria, and you can see this one looks much more angry. It's actually all over the body. It's on the torso, on the arms, it's on the leg, it's under the neck as well. It's swollen, it's red. There's little bits, there's big bits, some of it's confluent, but it's all urticaria. Right. So BCYP have got a really good guideline about urticaria. It's really good for adults. It's also really good for kids. It's worth having a look at if you want to recap yourself. And it's what we all tend to use in the allergy sector. The important things are that you're ruling out triggers, so you're working out whether is it urticaria or is it food allergy. Sometimes if it's chronic, so if it's longer than 6 weeks, if you've got any other concerns, if it's not responding to your simple antihistamines, you might need to think about doing additional investigations. Those are more likely to be done in a tertiary service. Are you just getting urticaria and angioedema, or is it just angioedema? Because if it's just angioedema and it's not got a skin component, then you need to think about C1 esterase, because that is the hallmark of that condition. All urticaria patients get a personalised management plan, and that will be about potentially thinking about triggers, but also thinking about symptom management. And they're all treated with antihistamines. So cetirizine is much the first line, chlorphenamine, etc. we don't really use anymore. And they start on a cetirizine standard dose that can then be doubled. And actually, in the tertiary services, we use that at 4 times the licensed dose, and that's off-label, but it's very well documented and as part of the British and European guidance. Fexofenadine is sometimes worth considering because it gives a longer pharmacokinetic profile, and so sometimes can give better symptom control rather than that sort of on-off. And really, there aren't any other treatments for urticaria. So sometimes people come and they've been prescribed steroid creams and things like that, and there isn't a role for any of those. Antihistamines really are the main medication to be used in urticaria, and anything else that might be considered needs to be done in a tertiary setting. We have an excellent advice and guidance service, which tends to get back to people quite quickly. So if you do ever have any concerns, if there's a patient that you want to ask some questions about, then you can get in touch with us and we can give you advice. We can help sort of differentiate or decide whether patients need referring whilst they're waiting to then be seen, because the delay can sometimes be quite long, and obviously you might need a bit of input before there, which we're very happy to give. We've got no time left to talk about rhinitis, which is not ideal because that's also very common. So I'm going to absolutely whiz through and just say that you can differentiate by what time of year, whether it's grass or tree birch, but we can do allergy testing within the service. Whereas house dust mite and animal dander are going to have an all year round pattern, and actually they can often get worse in winter because you're inside more. It can present differently depending on how old you are and how able you are to articulate. The investigations are similar to allergy. This is still an atopic disease, and we do skin prick testing for the specific aero allergens and then sometimes specific IgE, but actually a lot of the time it's not necessary. A lot of the bulk of management is actually advice and lifestyle advice, and then moving on to medicines. This is, so medicines to you, I can send these slides around later and you can have a look, but this is some excellent advice about managing aero allergens, so grass and pollen. And then there's some similar advice, and this is from Allergy UK about house dust mites. Medicines wise, again, it's cetirizine, so antihistamines starting on a standard dose, then going up to double. There's a role for nasal steroids, but lots of children find them difficult. Nasal antihistamines, again, there's a role, but they're even more disgusting in terms of taste, and so children sometimes really don't get on with them. And then for those children who are maximal medical therapy, there is a role for immunotherapy, but they have to have proven that they failed on traditional therapy first. Again, I'll send around these slides. There's a way to do nasal steroids and nasal drops, and we all tell everybody wrong, including me when I started this job. And it's all linked. So if you've got a child with allergic rhinitis symptoms, really bad hay fever or dust mites, you need to be thinking about asthma as well. If they've got asthma, you need to manage their asthma as well as their allergic rhinitis. And if they've got asthma, but they've also got symptoms of allergic rhinitis, you need to manage both because they're related and they exacerbate each other. It's really bad. It makes you lose a grade at GCSE. It makes really miserable. It's not sort of just hay fever. And this is just a picture of how miserable these kids. This is sort of what you see on TV, the 1-3 at the top, all these very cute kids sort of sneezing a little bit in a field. But actually, hay fever is really miserable and it really affects people. So treating it quite aggressively is important. As I said, we've got a great advice and guidance service, so just get in touch. I'll send around the slides so you've got those resources to have a look at. Sorry if I didn't practice this first. It's clearly way too much in here to cover in half an hour. So anyone have any questions?
Yeah, can I ask, what about Montelukast? Does that have a role at all? And is that something that we should ever be doing in primary care, or very much leave to you guys?
So I think pediatrics in general is moving slightly away from Montelukast because of all the psychiatric side effects that are sort of coming out. So it's being used even less in terms of asthma. I think on the whole, no, Montelukast for allergy specific, for those sort of atopic conditions, there's probably kind of a very niche role for it, but it's not something that we use very often. And I think it is something that should be done in a tertiary centre. I think Anne's here. I don't know if she disagrees with that.
Hi. Lucy, well done. She whittle. Ruth, just to answer your question, and I'm sure I remember you sitting in on our clinics or someone. Good question about Montelukast. I think you're right. We used to use it as an adjunct in the same for rhinitis and for urticaria. So you would, as a rule of thumb for both conditions, you push up on the doses of antihistamine as the first port of call. And then we did used to add in Montelukast. I think we're using that less now. I was saying to Francis that we're just finishing off our urticaria and our rhinitis guidelines. So we have got it in there, but I think we're definitely using it a lot less. Yeah, I think the most important thing with both conditions, hay fever in particular, actually, I suspect I think we undertreat hay fever as a system, I would say. I think we do get referrals into secondary care. I think you guys probably do a much better job than we realise, because I think we are seeing them when we've got patients coming in requesting oral immunotherapy or sublingual immunotherapy. Tends to be the general trend. We do get we pick it up when they're coming in with asthma, actually, and that was one of the things I was going to say, is always remember airborne allergens can give you allergic asthma. We've had a couple of patients being sent in with anaphylaxis to an indeterminate origin and being referred in as an idiopathic anaphylaxis, and actually it's a patient who's got really good going rhinoconjunctivitis and undiagnosed asthma. And again, my top tip for the rhinitis in particular is really think about asthma. Again, and I know that's hugely challenging across the system, but you know, asthma's definitely there. I do think rhinitis in particular, as I said, either you guys do a really good job, and if, naturally I'm sure I'm talking to the converted, but I know Francis and I were having a conversation. I think there are some really bad hay fevers out there. And I think rather than going for the Montelukast, my top tip would be do the basics first. Do the basics first, and you know, notice it, number one, and certainly when you've got anyone coming into an asthma clinic, always inquire about have they got rhinoconjunctivitis, because you may well save that summer admission, for sure. Eater's history, Lucy, that was fantastic. Bringing back Eater's history has been signposted for food allergic children, but as a rule of thumb, the same principle arises for rhinoconjunctivitis. It's all about, you know, what's the time of the onset and the exposure. You know, is it seasonal or is it perennial? And do the basics first. You know, regular antihistamine. I think our guidance says double dose, but actually we're often using up to 4 times the total daily dose in older children. For hay fever, I would say for you guys, stick with the double dose cetirizine. If cetirizine isn't working, then maybe try fexofenadine and the nasal steroids. There's been I'm trying to think of how to say this politically correctly. There's been difficulty accessing our go-to nasal steroid, which has been Avamys and or Dymista. Dymista is the combination nasal steroid and antihistamine, but there's been UK-wide difficulties in accessing that. So alternative nasal steroids, and to the extent where now we're even just saying Avamys or equivalent, i.e. whatever you can get available, but fluticasone really would be the go-to. We tend not to use beclomethasone. I'm sure you know this from your ENT teaching, that the bioavailability and the benefit of Becanase, for example, is pretty poor quality actually, in children in particular. It tends just to go straight into the bloodstream, so we tend to just go fluticasone, or Avamys. Some people swear by Nasonex. You find the applicators though in younger children tends to be poorly tolerated, and think twice about diagnosis of hay fever in a younger child. Can happen. It can happen, and you do see it, and I definitely think we're seeing, kids from the age of 3 upwards having hay fever type symptoms, but just think twice before considering it. Yeah. And the only other pitfall,
and I think just to I was
Lucy.
just going to jump in. I was just with, I think, like a really, really important resource is Allergy UK. It's a really good website, and for parents to be able to go and read about it, but also it's got all of the lifestyle advice, and actually sometimes that's the thing that makes such a big difference, especially for those slightly milder patients.
The only other quick thing I was going to say, and it's quite literally hot off the press and not an uncommon reason, I'll just iterate it again. Rhinoconjunctivitis and or airborne allergens, as a rule of thumb, don't cause anaphylaxis. So technically speaking, don't warrant an EpiPen. So technically speaking, I've had 2 this morning who've got EpiPens. Once the patient has an EpiPen, it's very difficult to remove them. I think that's across the system, but it does cause asthma. So just put as a rule of thumb, airborne allergens don't typically cause anaphylaxis, but they will cause asthma, as I'm sure you know, having an EpiPen when you've got asthma as well, or you've got bad asthma requiring pediatric intensive care and or regular HCU admissions isn't necessarily a bad idea, but as a rule of thumb, airborne allergens don't cause anaphylaxis.
Any other questions? You've all been bombarded with too much allergy. Really.